Welcome to the Deep Dive. Today we're tackling a subject that's really fundamental to how our bodies work, yet often kind of flies under the radar. It's the fascinating interplay between our vascular system, our blood vessels, and our nerves.
Right.
Specifically, we're going to unpack how disruptions in blood flow can actually impact the health of our nervous system.
And to really get to grips with this, we're drawing on a pretty heavyweight source. Chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Yep, top-tier stuff.
So that gives us a really solid foundation for, understanding this intricate relationship.
Absolutely. And our goal here, as always, is to pull out the crucial knowledge for you. We want you to quickly gain a deep understanding, maybe have a few aha moments without getting bogged down in, super technical medical jargon.
Exactly. We've got some genuinely surprising information, I think, and we'll aim to keep it clear and, engaging.
Okay, let's get started then. So, just to set the scene quickly, remember, our peripheral nervous system, the nerves outside the brain and spinal cord, has two main parts. First, there's the somatic system that controls our conscious movements and sensations, like waving your hand or feeling something hot. Pretty straightforward.
Right, voluntary stuff.
Then there's the autonomic system. This works automatically behind the scenes, controlling things like heart rate, digestion, breathing.
Involuntary.
Exactly. And that's further split into the sympathetic, the fight or flight response, and the parasympathetic, the rest and digest mode.
And interestingly, they mainly use different chemical messengers, neurotransmitters. Acetylcholine and norepinephrine are the big ones here.
Right. And that difference can actually matter when blood flow is compromised, can't it? Like norepinephrine affects blood vessel constriction.
Yeah, it can have downstream effects on how well the nerves themselves are supplied with blood. It all ties together.
So how does this all connect to blood supply problems?
Well, that brings us to the main topic, ischemic neuropathy, which in simple terms is just nerve damage caused by a lack of sufficient blood flow.
Okay.
And this deep dive is really going to explore the mechanisms behind that, how and why it happens.
So let's start with the nerves themselves. You might think, okay, nerves, they must need a constant, really rich blood supply to work properly. But surprisingly, it's a bit more nuanced than that.
It really is. What's quite remarkable, actually, is that nerves have a relatively low demand for oxygen compared to many other tissues in the body.
Huh, really?
Yeah. This inherent characteristic gives them a degree, sort of a built-in resilience to ischemia. That's the reduced blood flow we're talking about.
That's unexpected.
Yeah.
So if they have this resilience, what makes them vulnerable? Why do they get damaged by lack of blood supply sometimes?
Well, while the smaller nerves might get by okay just with diffusion from surrounding tissues for their basic needs, larger nerves have developed more sophisticated ways to protect themselves. They have these multiple interconnected networks of tiny blood vessels, the vasonevorum, supplied by branches from nearby arteries.
Like a safety net?
Exactly. Think of it like a city with multiple roads feeding into it. If one gets blocked, there are usually other routes.
Makes sense.
Plus, the inner parts of these larger nerves have this extensive pattern of vessels on their surface, the epidural vessels, which adds another layer of security for blood flow.
Sounds like a pretty robust system, actually. You mentioned earlier that usually just interrupting blood flow to one small segment of a nerve doesn't cause injury.
Generally, yes.
So that sets up the question, when does it become a problem? When do these defenses fail?
Right. Usually these protective mechanisms work really well, but there are exceptions, and a key one we need to talk about is something called Ischemic Monomelic Neuropathy, or IMN.
Okay.
It's rare, thankfully, but it's a significant nerve injury that can happen after acute limb malperfusion, basically. A sudden, severe drop in blood flow to a limb. What you see is multiple areas of damage to the axons. Those are the long fibers of the nerve cells, particularly in the distal parts further down the limb. And this leads to various motor and sensory problems.
And IMN is often linked to a specific medical situation, isn't it?
Yes. It's most commonly seen, unfortunately, in patients who are getting hemodialysis access placed, often involving the brachial artery in the arm. And what makes it tricky to diagnose is that the symptoms, the numbness, weakness, can sometimes look a lot like other conditions these patients might already have, like diabetic neuropathy or uremic neuropathy from kidney failure.
So it's easy to miss.
It can be. But it's important to distinguish it because the underlying nerve damage in IMN is different. It doesn't show that typical pattern called Wallerian degeneration.
Wallerian degeneration.
What's that exactly?
It's the sort of classic breakdown process you see when a nerve fiber is cut or crushed to the axon itself and its myelin sheath, the insulation. They degenerate below the injury site.
IMN doesn't typically show that. Instead, the thinking is it's caused by altered blood flow in the very small vessels feeding the nerve, maybe initially causing just a temporary block in nerve signals. But if that lack of flow persists, it leads to those scattered axonal injuries further down. So the lack of typical Wallerian changes points towards a different kind of mechanism, probably related to those tiny blood vessels.
That's a very specific scenario.
Yeah.
What about more, let's say, common situations where blood flow is reduced? Does it matter if it happens really suddenly versus gradually over a long time?
Oh, absolutely. That's a really crucial distinction. Let's talk about acute ischemic neuropathy first, when the blood supply gets severely reduced or cut off suddenly.
Yeah.
Animal model studies have given us some clues here. They suggest there's maybe a window, perhaps around 6 to 10 hours, beyond which the nerve damage is likely to become irreversible.
6 to 10 hours.
Yeah. Initially, the nerve tissue can sort of draw on oxygen and nutrients that are just sitting there in the fluid around the cells, the interstitial fluid. And like we said, that collateral circulation within the nerve bundle itself offers some protection initially.
But that runs out.
Exactly. If the severe lack of blood flow, the ischemia continues, you get this buildup of waste products like carbon dioxide, oxygen levels plummet, and it creates this toxic local environment. High potassium levels, increased acidity, things that are really harmful to the nerve cell membranes and can ultimately kill the cells.
Nasty stuff. Do we know how long human nerves can handle that?
That's the thing. We don't have precise data on the exact tolerance of human peripheral nerves to acute ischemia without causing lasting injury. The animal models give us a ballpark, but it's not perfectly mapped out in humans.
Okay. And what about the flip side? Chronic ischemic neuropathy, when the blood flow is reduced more gradually over a longer time, like in someone with peripheral artery disease, PAD.
Right, PAD, where the arteries in the limbs slowly narrow. Research looking at nerve biopsies from patients with chronic PAD has shown some interesting, maybe slightly confusing patterns. They often show signs of what's called segmental demyelination. That's where the myelin sheath, the nerve's insulation, breaks down in patches.
Okay.
But you also see signs of remyelination, the body trying to repair that insulation.
So damage and repair happening at the same time.
Kind of. And you also see evidence of axonal degeneration, the nerve fibers themselves getting damaged, but also regeneration, the body trying to regrow them.
A mixed picture.
It is. And the really puzzling part is that the exact mechanisms driving these changes in chronic limb ischemia, well, they're still not completely understood. And maybe even more surprisingly, the severity of the chronic ischemia, how bad the blood flow actually is, doesn't always directly match up with how much nerve damage you see.
Wait, really? So someone with objectively worse blood flow might have less nerve damage than someone with slightly better flow?
It seems that way sometimes, yes. It's not a simple linear relationship.
That is unexpected. So it's not just less blood equals more damage over time. What else could be going on?
Well, one intriguing idea, a hypothesis really, is that the nerve injury we see in these chronically ischemic limbs might not be from a slow, steady starvation of oxygen. Instead, it could be the accumulated damage from multiple repeated episodes of acute ischemia, maybe brief periods where the already poor flow gets even worse temporarily, and those little hits add up over time.
Like lots of small injuries adding up to a big problem.
Possibly. And adding another layer of complexity here is a really counterintuitive finding about something called ischemic preconditioning.
Okay, what's that?
It's where brief periods of reduced blood flow can actually protect tissues, like skeletal muscle, from damage during a later, longer period of ischemia. It sort of prepares the tissue.
Right, I've heard of that. Helpful for muscle.
Yes, but, and this is the twist, that same process seems to be harmful to peripheral nerves. Preconditioning that helps muscle can actually hurt nerves.
Wow. Okay, so nerves really play by their own rules sometimes.
It certainly seems that way. Different tissues respond differently to the same stresses.
Now, shifting gears slightly. We've been talking about poor blood flow causing nerve issues. But what about when we're actually trying to fix the blood flow problems? Can the vascular treatments themselves sometimes cause nerve injuries?
Oh, absolutely. That's a major consideration
Hmm.
because peripheral nerves often run right alongside major arteries and veins,
They're neighbors.
very close neighbors. They are definitely at risk of what we call iatrogenic injury, basically, injury caused by the medical treatment itself during vascular procedures.
Right.
So, a really thorough understanding of the anatomy, knowing exactly where those nerves are in relation to the vessels you're working on, is just paramount for vascular surgeons.
You could fix the plumbing, but damage the wiring in the process.
Precisely. You could successfully restore blood flow to a limb, but if you're not incredibly careful with the nearby nerves, you could inadvertently cause significant neurological problems.
Are those injuries that happen during surgery usually permanent? Or can they get better?
Well, the good news is that the majority of peripheral nerve injuries that happen just from, say, exposing the vessels during surgery tend to be transient, temporary.
Okay.
It causes a temporary nerve dysfunction called neuropraxia. Basically, the nerve signal is blocked for a while, but the nerve structure itself isn't permanently damaged. These often resolve over time. However, if a nerve actually gets cut or tied off, what we call division or ligation, then yeah, that damage is permanent.
Right. Can anything be done then?
Reconstruction of divided nerves is possible surgically. You can try to repair them, and we can see acceptable rates of functional recovery sometimes, but the outcome really varies depending on which nerve it is, how bad the damage was, how quickly it's repaired. Lots of factors.
What are some other ways nerves can get hurt during these procedures? It's not just cutting them, right?
No, definitely not. Several things can happen. Nerves can get stretched or compressed by retractors, the tools used to hold tissues apart so the surgeon can see and work. Thermal injury from electrocautery devices, the tools that use heat to stop bleeding, that's another risk if it gets too close to a nerve.
Ouch.
Also, if a hematoma forms, that's a collection of blood, like a bruise, but potentially large and putting pressure on things. If that forms near a nerve, it can compress it. Or even just how the patient is positioned on the operating table for a long time, if there's pressure on a vulnerable nerve, that can cause injury too.
So many potential pitfalls.
It really underscores why meticulous surgical technique and just constant awareness of that nerve-vessel relationship are so critical.
But there's some hope even if an injury does happen.
Yes, thankfully. Except in cases where the nerve is completely severed, peripheral nerves actually have a remarkable capacity to regenerate. They can regrow.
That's amazing.
It is. So in most instances of injury short of complete division, we generally see favorable functional outcomes eventually, although recovery can be slow.
Okay, that's good to know. But it's also important to remember, I guess, that not every nerve problem someone has is automatically due to blood flow issues or surgical trauma,
Yeah.
right? There could be other things going on.
That is a hugely important point. When a doctor is evaluating someone with neuropathy nerve symptoms, they absolutely have to consider other potential causes. We call that the differential diagnosis.
Right.
And for vascular specialists, probably the most common alternative cause of peripheral neuropathy they run into is diabetic neuropathy.
Yeah, unfortunately, that's incredibly common. What makes someone more likely to get diabetic neuropathy?
Well, the risk factors are pretty well known. Things like increasing age, how long you've had diabetes, how well controlled your blood sugar levels are or aren't.
Right.
Also issues with lipid metabolism, high blood pressure that isn't managed well, obesity, and something called metabolic syndrome.
And how does diabetes actually damage the nerves? Is it just the high sugar?
It's complex and honestly not fully understood even now. But yes, the metabolic chaos caused by chronically high blood glucose and problems with insulin regulation are thought to be major factors.
Okay.
But interestingly, damage to the tiny blood vessels, the microcirculation, is also believed to play a really significant role in diabetic nerve damage.
Ah, so there's a vascular component even in diabetic neuropathy.
Exactly. Which can sometimes make it really tricky to tell the difference between purely diabetic neuropathy and neuropathy caused by larger vessel ischemia, or maybe a combination of both. The lines can get blurred.
That does sound complicated. Are there other major causes of neuropathy besides diabetes and the vascular issues we've discussed?
Yeah, there's a fairly long list. Things like excessive alcohol consumption over time, kidney failure leading to uremia, the buildup of waste products, intoxication from certain drugs, side effects from various medications. Chemo drugs are a common example. Also vasculitis, which is inflammation of the blood vessels themselves, autoimmune disorders where the body attacks its own nerves, certain infections, and other inflammatory conditions.
Wow. Lots of possibilities. Is there anything about those types that helps distinguish them?
One common feature, though not universal, is that many of these other types of neuropathies tend to be symmetric, meaning they affect both sides of the body, like both feet or both hands, in a similar way. Ischemic neuropathy, especially from PAD, is often more pronounced on one side.
Okay, that's a useful clue. So, given all these possibilities, how do doctors actually go about diagnosing nerve problems, especially when they suspect a link to vascular issues?
Well, it always starts with the basics. A detailed patient history, asking lots of questions about the symptoms, when they started, what makes them better or worse,
Right.
and a thorough physical examination. In the lower extremity, for example, signs of neuropathy might include slight weakness, say in the ankle muscles, or maybe depressed reflexes like the ankle jerk isn't very strong. Often their sensory loss may be affecting one side more, and typically in what we call a stocking distribution, starting in the toes and foot and gradually moving up the leg, like putting on a stocking.
Ah, I see.
And this sensory loss often particularly hits the ability to feel vibrations. You might use a tuning fork to test that. Over time, you might even see atrophy, where the small muscles in the affected foot actually get smaller, they waste away.
Hmm.
And the type of pain is important too. We mentioned neuropathic pain earlier after blood flow is restored to a very ischemic limb. This nerve pain might persist.
Right, the burning pins and needles type.
Exactly. Often described as burning or paresthetic, maybe worse at rest or at night, and usually not relieved by walking around. The person might say their foot feels cold, even if it's actually warm when you touch it. Stiffness or reduced toe movement can also happen.
How does that kind of pain compare to the pain that's directly from the lack of blood flow itself, the ischemic pain?
That's a really key distinction doctors try to make. Ischemic rest pain, the pain purely from not enough blood getting there, is often relieved, at least somewhat, by dependency letting the leg hang down over the side of the bed, for example.
Right.
Gravity helps pull a little more blood down. And generally, with ischemic rest pain, the limb will actually feel cool or cold to the touch compared to the other side or compared to normal.
Got it. So the pain characteristics, the limb temperature, dependency effects, those are all important clues from the history and exam. What about specific tests?
Vascular testing is absolutely crucial. Things like measuring ankle pressures or toe pressures.
Right.
For instance, an ankle pressure below 40 millimeters of mercury or a toe pressure below 30 strongly suggests that the blood flow is really inadequate.
Okay.
Also, using Doppler ultrasound to listen to the blood flow waveforms, if you see what's called a monophasic waveform, that flat signal, that also points to severe arterial insufficiency.
And if those tests show poor blood flow?
Then the priority has to be improving that perfusion, trying to revascularize the limb, get more blood flowing. Ideally, any necessary neurologic testing should happen around the same time as efforts to fix the blood flow.
Makes sense. Fix the supply problem first. What if the vascular tests are okay, though? Or the symptoms persist even after blood flow is restored?
Right. If there's no clear evidence of significant arterial insufficiency, or if the nerve symptoms don't improve after revascularization, then a more focused neurologic evaluation is definitely needed to explore those other potential causes we talked about.
And what does that neurologic evaluation usually involve? What kind of tests?
This is where electrophysiologic testing comes in. That includes nerve conduction studies, NCS, and electromyography, EMG.
Okay, the tests with the little shocks and needles.
Kind of, yeah. They can be very helpful in confirming, yes, there is neuropathy and figuring out how severe it is and maybe what type.
So what do those tests show in ischemic neuropathy specifically?
In ischemic neuropathy, we often see a pattern suggesting what's called unilateral axonal neuropathy.
Unilateral,
Mhm.
one-sided, axonal,
Mhm.
affecting the nerve fiber itself.
Exactly. Primarily affecting the nerves further down the leg, like the distal tibial and peroneal nerves. When they do the motor nerve conduction studies stimulating the nerve and recording the response in a muscle, they might find that the electrical response in the foot muscles, the amplitude of that signal, is decreased, maybe even absent.
Okay, the signal strength is down. What about the speed?
Interestingly, the speed at which the signal travels along the nerve higher up in the calf, the conduction velocity, is often relatively preserved, especially early on.
So weak signal, but normal speed.
Relatively speaking, yes. And that pattern, reduced amplitude but relatively normal velocity, can help distinguish ischemic neuropathy from, say, diabetic or uremic neuropathy. In those conditions, you often see a slowing of the conduction velocity much earlier, and it usually affects both sides more symmetrically.
Ah, okay, so the pattern to damage is different.
It points towards damage primarily to the axons, the fibers themselves, especially distally, rather than a primary problem with the myelin insulation causing slowing along the whole nerve length, which you might see more in other types.
Gotcha. What about the sensory nerves in these tests?
Similar picture, often. Sensory nerve conduction studies might show that the electrical signals from sensory nerves in the foot and ankle, like the sural nerve or the plantar nerves, are reduced in amplitude or even completely absent.
Okay.
But again, if you can record a signal, the speed it travels, the sensory conduction velocity, is often still within the normal range.
And the needle part, the EMG, what does that show?
The needle electrode examination involves putting a very fine needle electrode directly into specific muscles to record their electrical activity.
Right.
In ischemic neuropathy, this might show signs of muscle denervation, evidence that the nerve supply to the muscle is damaged. You might see abnormal, spontaneous electrical activity when the muscle is supposed to be resting, and changes in the electrical signals generated when the person tries to contract the muscle. These changes suggest the nerves aren't properly telling the muscles what to do, particularly in the small muscles in the sole of the foot.
That paints a really detailed picture of how these tests can pinpoint the problem. So once a diagnosis is made, or strongly suspected, what are the general principles for treatment?
Well, for patients who have both acute arterial ischemia and acute ischemic neuropathy, that sudden onset scenario,
Yeah.
the absolute primary urgent goal is rapid revascularization. Get the blood flow back to that limb as quickly as possible.
And does that usually help the nerve symptoms?
Often, yes. Restoring blood flow can lead to improvement in the motor and sensory symptoms of the neuropathy, sometimes quite quickly after the procedure or sometimes gradually over the following weeks.
What about the chronic type? Does fixing the blood flow help them?
With chronic ischemic neuropathy, unfortunately, revascularization alone is less likely to lead to significant improvement in the established nerve symptoms. The damage might be too long-standing. So, if symptoms of neuropathy persist even after blood flow seems adequate, it's really crucial to circle back and rigorously exclude those other potential causes, diabetes, medications, etc.
And what about tackling the pain? You mentioned neuropathic pain can be really tough.
It really can be. Treating neuropathic pain, especially the kind associated with ischemic neuropathy, is often quite challenging. The usual suspects for post-surgical pain, like standard pain relievers or anti-inflammatories, NSAIDs, they're generally not very effective.
So what do you use?
Well, the first-line pharmacologic therapies, the medications usually tried first, often include things like tricyclic antidepressants, TCAs.
Antidepressants for nerve pain.
Yes, they work on nerve pathways involved in pain signaling. Amitriptyline is a common example. While TCAs can be effective for some people, they do have potential side effects, including some effects on the heart. So they have to be used carefully, especially in older patients or those with existing heart conditions.
Okay. What else?
Another class is the selective serotonin and norepinephrine reuptake inhibitors, or SSNRIs. Duloxetine is one. They generally have a better side effect profile than TCAs, fewer cardiac worries.
That sounds better.
But their effectiveness for neuropathic pain can be a bit inconsistent. Works well for some, not so much for others.
Hmm.
Then there are the calcium channel alpha-2 delta ligands. Big name, but the common drugs here are gabapentin and pregabalin.
Right, I've heard of those.
They're very commonly used as first-line treatments too, but again, they don't reliably provide pain relief for everyone. Common side effects can include drowsiness, dizziness, and the dosage often needs careful adjustment, especially if someone has kidney problems.
So it sounds like finding the right pain medication can be a process of trial and error for many patients.
It often is, unfortunately. It can take several weeks, sometimes months, of trying different medications or doses to find something that provides meaningful relief with tolerable side effects.
Okay. What about treatment for those traumatic nerve injuries, the ones that happen during surgery?
Right. As we touched on, if it's a partial loss of nerve function after surgery, like a neuropraxia or a mild injury,
Yeah.
there's generally a good chance of recovery over time because of that inherent ability of peripheral nerves to regenerate.
That regrowth thing, how fast does that happen?
The estimate is roughly 1 millimeter per day.
Wow, that's slow.
It is. So depending on how far the nerve has to regrow to reach its target muscle or skin area, recovery can take a very long time, months, even over a year in some cases. Patience is key.
What if the injury seems more severe right after surgery?
Yeah.
Like major weakness or numbness?
If there's a significant loss of motor and sensory function immediately after a vascular procedure, surgical re-exploration of the area might be necessary.
Going back in.
Yeah, to take a look. If a major nerve or one of its important branches is found to be actually cut, then surgical repair, trying to sew the ends back together, is definitely indicated to give it the best chance to regrow correctly.
Makes sense.
Or if the problem seems to be acute compression, like from that hematoma we mentioned.
The collection of blood.
Right. Prompt surgical decompression going in, draining the hematoma, and relieving the pressure on the nerve can often lead to a really good recovery of function.
Okay. What if symptoms just linger for a long time without getting better?
Well, in cases where symptoms persist, there's no sign of spontaneous improvement, and maybe those nerve conduction studies confirm ongoing nerve damage or blockage, then surgical exploration might be considered again. This time, the goal might be neurolysis, carefully freeing up the nerve from any scar tissue that might be trapping or compressing it.
Okay.
And in some cases, if there's a gap in the nerve that can't be repaired directly, nerve grafting might be an option, taking a piece of sensory nerve from somewhere else, like the leg, and using it to bridge the gap in the damaged motor or sensory nerve.
Wow, complex stuff. Does that work well?
It can offer some hope for functional recovery in difficult situations, and there have been some encouraging results reported in recent studies, but it's certainly a challenging area of reconstructive surgery.
It really is fascinating, though, learning about all these different ways nerves can be injured during vascular procedures and how the consequences and treatments can vary so much.
Yeah.
Let's maybe dive into some specific examples now. Nerves that are commonly at risk with particular types of surgery, starting maybe up top with the carotid artery in the neck?
Sure. Surgery to expose the extracranial carotid artery, which is done frequently for procedures like carotid endarterectomy to clean out plaque,
Right.
puts several cranial nerves and other nerves in the neck area at potential risk. The vagus nerve is a big one. Injury there can cause hoarseness, maybe difficulty swallowing.
Okay.
Branches of the vagus, like the external branch of the superior laryngeal nerve, can affect your ability to hit high notes when speaking or singing. The recurrent laryngeal nerve, another vagus branch, is notorious for causing hoarseness or even vocal cord paralysis if injured.
Wow.
Then there's the hypoglossal nerve. That controls tongue movement. Injury can make your tongue deviate to one side, cause swallowing problems, slurred speech. The marginal mandibular nerve, that's actually a branch of the facial nerve, runs near the jawline. If that gets nicked or stretched during the incision, you can get that characteristic droop at the corner of the mouth on that side.
Oh, I've seen that.
Less commonly, the glossopharyngeal nerve involved in swallowing and gag reflex can be affected. Even manipulating the carotid sinus area can stimulate the nerve of Herring, potentially causing temporary drops in heart rate or blood pressure right after surgery.
So many.
The spinal accessory nerve, controlling a major shoulder muscle, is usually safe in standard carotid surgery. But the great auricular nerve, which provides sensation to the skin around the earlobe and lower ear, that often gets cut with the incision, leading to numbness in that area, sometimes persistent.
It really highlights how crowded that area is anatomically.
It absolutely does. Even slight variations in anatomy or dissection can put different structures at risk. You really see how proximity is the key issue across all these examples.
What about procedures a bit lower down, say in the upper chest or shoulder area, working on the subclavian artery under the collarbone, or maybe axillary vessels in the armpit?
Okay, yeah. With surgical exposures in the supraclavicular region above the collarbone or through thoracotomy incisions, cutting into the chest wall, different nerves come into play.
Right.
The phrenic nerve is a major one here. It runs down through the neck and chest to control the diaphragm, our main breathing muscle.
Crucial nerve.
Very. Injury during exposure of the subclavian artery or certain chest surgeries can paralyze half the diaphragm, potentially leading to shortness of breath, especially when lying down, and maybe more susceptibility to lung infections.
Yikes.
Then there's the long thoracic nerve. It runs down the side of the chest wall and supplies a muscle called the serratus anterior, which holds your shoulder blade flat against your back.
Okay.
If that nerve gets damaged, you get a winged scapula. The shoulder blade sticks out prominently, especially when you push against something, and lifting the arm overhead can be difficult.
Wing scapula. Memorable name.
And finally, the intercostal nerves, which run between the ribs. They're almost inevitably stretched or sometimes cut during thoracotomy incisions. This often leads to intercostal neuralgia, that persistent, burning, or sharp neuropathic pain along the chest wall where the nerve was affected can be quite bothersome.
Moving further down the arm.
Yeah.
What about the brachial plexus, that big bundle of nerves in the shoulder and the nerves in the arm and hand itself?
Right. The brachial plexus is that complex highway interchange of nerves deep in the shoulder and neck that eventually branch out to supply the entire arm and hand.
Okay.
The individual nerves coming off it, the axillary, musculocutaneous, median, radial, ulnar nerves, they can all be injured by various means during procedures involving the axillary artery up high or vessels further down, like the brachial or basilic vein in the arm.
How so?
Well, for example, attempts to put a catheter in the brachial artery. Or if a hematoma, that blood collection, forms within the sheath surrounding the vessels and nerves in the upper arm, that can compress the median nerve. That can cause weakness in thumb and index finger flexion, sometimes called the orator sign or benediction sign because of how the hand looks.
Interesting. What about the ulnar nerve, the funny bone nerve?
Yeah, the ulnar nerve runs along the inner side of the arm and behind the elbow. It can get injured during surgery on the basilic vein or ulnar artery nearby, or honestly just from prolonged pressure on the elbow if the arm isn't positioned carefully during a long operation.
Right.
Ulnar nerve injury typically causes numbness and tingling in the little finger and half of the ring finger, plus weakness in the small muscles of the hand, affecting grip strength.
And the radial nerve.
The radial nerve wraps around the back of the humerus, the upper arm bone. It's vulnerable to fractures of that bone, shoulder dislocations, or sometimes just prolonged compression, like if someone falls asleep with their arm draped over a chair, Saturday night palsy. Radial nerve injury famously causes wrist drop, inability to extend the wrist and fingers because it supplies those extensor muscles.
Gotcha. Even smaller nerves.
Oh yeah. Even the medial antebrachial cutaneous nerve, just a sensory nerve for the inner forearm, can be injured when creating dialysis access shunts in the arm. Or the superficial branch of the radial nerve down near the wrist can get nicked during radial artery harvest for heart bypass surgery, or even from repeated punctures for cardiac catheterization through the wrist, causing numbness on the back of the thumb side of the hand.
So positioning during surgery is really key for the arms, too.
Absolutely critical. Prolonged pressure or stretch on the brachial plexus itself due to poor arm positioning is a well-known cause of potentially devastating nerve injury.
Okay, let's move down to the abdomen and pelvis. Big surgeries there on the aorta and the iliac arteries that branch off into the legs. What nerves are at risk there?
Right, major vascular surgery territory. Procedures on the aorta and iliac arteries can potentially affect nerves that are part of the autonomic nervous system, specifically the superior hypogastric plexus and the hypogastric nerves themselves.
And what are those controls?
They play a really critical role in sexual function, particularly ejaculation in men. So, injury during dissection for, say, an aortic aneurysm repair or bypass surgery can unfortunately lead to complications like erectile dysfunction or retrograde ejaculation.
Retrograde ejaculation.
Yeah, where semen flows backward into the bladder during orgasm instead of forward out of the penis.
Ah, okay. Can surgeons avoid injuring those?
Experienced surgeons are very aware of this risk and often take specific precautions. They try to preserve these nerve structures, at least on one side, whenever technically possible during aortoiliac surgery, to minimize the risk of these sexual side effects.
Anything else related to sexual function?
Yes, sometimes during aneurysm repair, the inferior mesenteric artery needs to be tied off from inside the aneurysm sac. Doing that can potentially injure the nerve plexus around that artery, the inferior mesenteric plexus, which also contributes to the hypogastric plexus, again increasing the risk of sexual dysfunction.
What about less invasive procedures like endovascular aneurysm repair, EVAR? Still a risk.
Less risk than open surgery generally, but yes, EVAR can still have implications for sexual function, particularly if the procedure involves blocking off the internal iliac arteries with coils or plugs embolization to prevent blood flow from feeding back into the aneurysm sac.
Why does blocking those arteries affect sexual function?
Because the internal iliac arteries supply blood to the pelvic organs, including those involved in sexual function, and the nerves run close by. Reduced blood flow or direct nerve effects from the embolization materials can cause problems.
Are there ways to reduce that risk with EVR?
Yes, strategies include maybe staging the procedure, doing it in parts over time, being very precise with coil placement to avoid nerve structures, and using newer branched stent grafts that are designed to maintain blood flow through the internal iliac arteries while still sealing off the aneurysm.
Okay. What about nerves controlling the legs that might be affected by these big abdominal or pelvic surgeries?
Good question. The lumbosacral plexus, that's the big network of nerves formed from the lower lumbar and sacral spinal nerve roots, located deep in the pelvis, is also potentially at risk during aortoiliac interventions.
And how can that get injured?
Several ways. Direct injury during surgical dissection in the retroperitoneal space where these nerves lie. Excessive traction or stretching of the nerves by retractors during the procedure. Ischemia, reduced blood flow to the nerves themselves, maybe from clamping major vessels, or if a clot forms in the internal iliac artery, which supplies blood to the plexus.
And what happens if the lumbosacral plexus is injured?
It typically results in unilateral one-sided motor and sensory loss in the leg, often affecting multiple dermatomes and myotomes, meaning areas of skin sensation and muscle groups supplied by different nerve roots from the plexus. It can be quite widespread weakness and numbness in one leg.
How do you tell that apart from, say, a spinal cord injury that might happen during a complex aortic procedure?
That's an important distinction. Spinal cord injury usually causes bilateral symptoms, often with a clear sensory level, and potentially changes in reflexes like spasticity or hyperreflexia below the level of injury. Lumbosacral plexus injury is typically unilateral and causes flaccid weakness with reduced or absent reflexes in the affected leg.
Okay. And finally, what about nerves in the lower extremities themselves, during surgeries specifically on leg arteries or veins?
Right, lots of potential targets there too. During surgical exposures in the groin, thigh, or lower leg to treat peripheral artery disease or harvest veins, various individual nerves are vulnerable.
Like which ones?
Well, the lateral femoral cutaneous nerve runs near the groin crease. It can be compressed or injured during groin dissections, leading to meralgia paresthetica, that classic burning pain and numbness on the outer aspect of the thigh. Very annoying for patients.
Okay.
The obturator nerve, deeper in the pelvis but emerging near the femoral artery, can be affected during procedures there, causing numbness on the inner thigh and weakness in the adductor muscles that pull the leg inward.
And the femoral nerve itself, big nerve in the front of the thigh.
Yes, the femoral nerve and its branches, like the anterior cutaneous femoral nerve for sensation on the front of the thigh, and the saphenous nerve, which runs down the inner leg. They're all vulnerable during surgical approaches in the groin or thigh, especially with retraction. Injury can cause weakness in straightening the knee, quadriceps muscle, and sensory loss on the front and inner thigh and leg.
What about lower down the leg?
The sural nerve, a sensory nerve running down the back of the calf near the small saphenous vein, is at risk during vein stripping or harvesting or procedures near the ankle. Injury causes numbness or tingling, sometimes chronic pain, on the outer back of the calf and outer edge of the foot.
And the really big ones, sciatic tibial, peroneal.
The sciatic nerve itself, the largest nerve in the body, runs deep in the buttock and back of the thigh. While less commonly injured during standard peripheral vascular surgery, its main branches, the tibial nerve running down the back of the leg and the peroneal nerve wrapping around the head of the fibula bone near the knee, are definitely vulnerable. Patient positioning during long surgeries is a big one, especially for the peroneal nerve, which is superficial near the knee. Posterior knee dislocations can injure the tibial nerve, and severe ischemia itself, from critical limb ischemia, can damage these nerves, potentially causing foot drop from peroneal nerve damage affecting ankle dorsiflexion, or weakness and pushing off from tibial nerve damage affecting plantar flexion, along with significant sensory loss in the lower leg and foot.
It really is quite sobering, isn't it, to realize just how intricately connected our vascular and nervous systems are,
It is.
and the sheer number of potential points where they interact and where injury can happen, even during procedures meant to help.
Absolutely. I think the crucial takeaway here really is that this intimate relationship means that vascular problems and the things we do to treat them can absolutely have significant neurological consequences.
Yeah.
Even though, as we started out saying, nerves do have some inherent resilience, and diagnosing and treating ischemic neuropathy effectively. It's complex. You have to consider so many factors, rule out other conditions like diabetes. And as we've just gone through in detail, that comprehensive knowledge of anatomy and just meticulous, careful surgical technique are incredibly important for preventing nerve injuries during vascular procedures in the first place.
This has been a truly illuminating deep dive, really exploring an intricate, maybe underappreciated area of medicine. It certainly makes you think about all the delicate balances happening inside our bodies that we're probably completely unaware of most of the time.
Definitely.
So, for our final thought to leave you with today, considering this really delicate interplay we've discussed between blood supply and nerve function, what other seemingly unrelated systems in our bodies might have similarly intricate, perhaps surprising, interdependencies that we're only just beginning to fully understand?
That's a great question to ponder.
Gives you a lot to consider. Well, thank you for joining us for this deep dive.